more blasts that could be causing your white cells to go up, especially if you think, sometimes you say, this lab is giving me wrong results. White cells are very high, and clinically the patient doesn't look like they have any infection. So those are the things. So you need to know what lab is doing, and that's why we train. And in the drive for universal healthcare, we need to train as many clinical pathologists as possible for our government hospitals, so that then the very many specialists we are getting in the various departments can have support in terms of giving very good patient care. Okay, I have something on D-dimers. This is my second last. If I have time, I will look at it, and basically, I'll just say something that we all know that D-dimers are not specific tests, right? They have issues. They could be elevated in elderly patients, and sometimes they get to 2.5 times higher. How many of us still use the cutoff of 500 even for elderly patients when it comes to D-dimers? So you need to know that an elderly patient would have generally his levels, going up, and you need to interpret those results with a bit of care. Guidelines are that if your patient, you're suspecting PE or VTE, and your patient has another likely cause of an elevated D-dimer, please do not do the D-dimers. Yeah, because it will confuse you. If the patient is from a recent surgery, or patient is pregnant, patient is having other forms of chronic inflammations going on, that D-dimer will confuse you, right? So don't do it. Look for other modalities. And but the interesting thing about pregnancy, and I'll give a challenge to the obstetricians who are here, studies suggest that throughout pregnancy, up to delivery, that we can almost trace how the D-dimers go up and how they come down up to 6 weeks and they become normal at 6 weeks, about 6 weeks. And the recommendation from all of these studies is that we should get gestation-specific reference intervals that will make use of D-dimers better in pregnancy, so that then you can know if a patient is pregnant and is at 30 weeks, the normal D-dimers at 30 weeks is from here to here. So anything above that, then it can help you in say, ruling out your VTE. But importantly is that you need to know the type of tests and methods your labs are using. Because the recommendation is if a patient has a moderate probability, that you use high sensitivity D-dimer methods. You use high sensitivity D-dimer methods. And these three, ELISA, alpha, and immunoturbidimetry, are high sensitivity, while the whole blood point of care is a moderate sensitivity. And the recommendation is that you use high sensitivity in such cases. So you need to be aware of what your lab is doing. And then D-dimers are also not standardized at all. And there are two methods of doing them, what we call the purified D-dimer and the fibrinogen equivalent units. The problem with this is that the fibrinogen equivalent unit is the mass, because their mass methods are approximately 2 times the DDUs. That means if you do a test in DDU and you do it with an FEU method, that the results are usually 2 times. So imagine you're sending a D-dimer today to one lab, and then you're monitoring that patient, and then sending another one to another lab without knowing what methods they're using. Then you actually get confused. You cannot even monitor these patients. And for labs like our lab at Metropolis, we will always, if you give your D-dimer result, we will write in bracket what method we are using, what mass type we are using, so that then you can compare your patients even across the methods and so on. So that if you get a result, you should query what type of method was used, what is the mass units that were used, yeah? And those are very important things to pick up. And I think I'll probably do my final case here. This is about, and maybe the only cancer case that I said I will touch on, BCR-able CML patients, yeah? So when you suspect a CML, how many of us want to do a Philadelphia chromosome? Okay, 1, 2, 3. Okay, how many of us want to do BCR-ABL instead? Okay, so there are different tests. I mean, your Philadelphia chromosome is basically just finding out the chromosomes, you know, and how they look like, and so on. BCR-ABL, on the other hand, looks for the mRNA transcript of that abnormal gene, right? And it's been found that if you look at sensitivities, if you're using cytogenetics compared to FISH, compared to PCR, your cytogenetics, your sensitivities are very different. You'll find that PCR methods are very sensitive. And right now, we're even going to what are called now the digital types of PCRs. They're able to pick very low amounts of circulating mRNAs. And that is very important. Secondly, you do methods that are quantitative. So you do a quantitative method because the recommendation right now is that you need to monitor your treatment using BCR-ABL. So if you found that the initially BCR-ABL was 30% and you're monitoring your treatment, then you need to use the same method and monitor using the same method. So you cannot do Philadelphia chromosome at diagnosis and then get stuck at monitoring. You don't know how to monitor that patient because you don't know what the baseline disease burden was. And look at this. Initially, we just used to talk about what is called the major molecular remission, where you get levels of BCR-ABL up to 0.1%. The tests are very sensitive now, and we're able to go up to 0.01, and you can see here. We are now going to what is called the deep molecular remission. So patients, and you're following up, you want to use a method that is sensitive enough to pick your deep molecular remission. So your choice of tests are very important. So you would not just send a test without knowing what to expect. You need to know what you're looking for, what is the sensitivity of the test that you're going to use, and how is that going to impact once you get the results. Sometimes, you get those results and you get confused. You're like, oh, now what next? So you need to be aware of the kind of tests that are available and their sensitivities and the kind of utility you can get from them. The recommendation right now is that you do 3 monthly BCR-ABL, the quantitative one. So at diagnosis, you pick up the diagnosis, you document that, and then do 3 monthly. Initially, people are doing it even at 12 months only, just to pick the major molecular remission. But right now, studies are showing that there's something called the early molecular response. Immediate 3 months after you've started your treatment, if your BCR-ABL is less than 10%, those are patients who are likely to do better, and they're likely to respond to your first line. If they don't, if the value is above 10%, then those are patients you monitor closely. They're likely to be patients that you may need to change to second line TKIs and so on. So I think with that, I will stop. There's definitely so much we can still interact offline. Thank you.
Thank you so much, Dr. Ali Kasim, for this interactive session. I think now the concentration has gone up slightly. So now it's the session for question and answer. Dr. Bajabir, he has some of the questions which came through the portal. And if you have any question, you can ask even, it's not only anonymous, you can also boldly stand and ask any question to our panel of presenters. So role of surgery, alternative care in oncology, prognostication of breast cancer, role of clinical pathologist, basis of cancer treatment, and role of clinical pathologist. So there were like 6 presentations. I know it's very challenging to keep track of all of them. So one of the questions is for Dr. Kasmani. Is there an avenue for sperm and ovum preservation in Kenya for patients undergoing chemo-radio? And if yes, what is the average cost?
There is a sperm bank in Nairobi at Kenyatta Hospital, basically in University of Nairobi. So yes, sperm banking can be done. Though for ovum harvesting, I don't think there is yet in Kenya. Yes, the cost a few years ago of sperm banking used to be about 5,000, right? Yeah, you can get your sperms and bank them, and they keep them for you. It wasn't a very big cost, but ovum harvesting is not yet there.
So for females, the option is oocyte preservation, where they go through a process of stimulation of follicles, and then when you get the oocytes, you preserve them. But it's not translation of oocyte preservation to an actual pregnancy is at the rate of about 15 to 20%. So it's not very high, and on average, it's going to be about between 400,000 and 500,000. The challenge with that is that because there is the pre-stimulation process, it might delay your treatment by 3 to 4 weeks, which in some patients might not be appropriate.
But it's not available in Kenya, is it? Yeah.
So second question, I think it's, I understand most of the cancer patients end up dying. What is the major cause of their death? How can we minimize or prevent it?
Well, you know, if you are detecting cancer when it is already in advanced stages, and as I said, almost our 80% of cancers are detected in stage 4. That means that it is already in incurable state. So whatever treatment we are giving at that juncture, as I said, it is with palliative intent. So at one point or another, yes, they will die. We are probably palliative intent means that we are trying to make their life comfortable. We are trying to decrease the cancer burden so that it doesn't cause a lot of distress, it doesn't spread further. We are also trying to some extent that we could increase the overall survival. But one day, all those cancer cells with all the treatments, they'll become resistant, and the eventual fate of the person will be death. That is in advanced cases. In earlier stages, yes, we expect a cure, and we have many, many patients who have been cured of cancer and are surviving and are cancer-free. So it's essential that you need to know what is our intent of treatment. And then there are some cases whereby they are so advanced that actually giving them any mode of treatment might be more disastrous than just giving them best supportive care. So it's essential that we detect patients who will benefit from a treatment and patients who will not benefit from any treatment. You have anything to add?
Yeah, so I think it's a bit of a misconception when you say all cancer patients are going to die. I mean, all of us are going to die. Life is a terminal illness, so eventually we are all going to die. So like Ria says, I mean, I'm sorry, but this yeah, so essentially if you get your cancer early, the cure rates are higher. If you have more advanced disease, the chances of cure are not there. But when we go with a misconception that every patient with cancer dies eventually, we sometimes prevent them from getting access to care that is helpful to them. It might be palliative care, which is controlling symptoms, relieving pain, improving feeding, and palliative care sometimes improves survival for up to 5 to 10 years, which allows people to do things that they would have wanted to do. So it's very important that we give hope to patients even when they're in the advanced stages, and focusing on preventive health, which is preventing risk factors and early diagnosis for patients. What I wanted to say is do you know the rate of death from heart failure? So in 5 years, 50% of all heart failure patients die. So for some cancers, the mortality rate is higher for heart failure than it is for cancer.
My question is for Dr. Sidna. At what level of regulation are we having the alternative therapy providers being regulated? Is there a process ongoing, or are we just at a loss?
So, I mean, globally, it's not, because it's considered to be outside the normal practice, there's not much regulation. But increasingly, bodies like the National Cancer Institute in the US actually has a division for complementary and alternative therapies in recognition that, and in Kenya we have a similar platform, in recognition that we cannot pretend that it's not happening. The challenge is when you have almost 40,000 people in Kenya doing traditional medicine, and they're not on any registered platform, how do you then regulate that? It becomes a challenge, but I think having them under a Health Act is the first step, and then actually having steps to identify the providers, what they're providing, and also sometimes educating them that, so like if you look at maternal health, people were like, so how do we help women who are going to traditional birth attendants? It's by educating traditional birth attendants to know that this is my limitation. When I reach this point, I need to refer this patient to a health facility. So similarly, if you could use that as a pilot or a system to say you're the ones offering this service, you know that if it reaches a certain point, you're not offering care, and it is only justice, to refer patients for other care.
Assalamu alaikum. I have a question concerning complementary therapies. There's something interesting I came across sometime last year. It's about hydrogenized water. So it was a device that converts water to split it up to hydrogen and OH. So the idea was in cancer cells, they produce negative radicals, that's like negative O, which combines with the free hydrogen ion. So it combines and forms water.
The science behind them sometimes is not logical, or you cannot prove it scientifically. There are many things about water and oxygen. So there's something like hydrogen therapy, there's acidic therapy, there's hydrogen. I mean, I just don't think that there's any evidence that it is beneficial at this point in time, but that may change if we have solid research either way. Yeah. I have a question here about marijuana, and how is marijuana used to stop the vomiting? Is it by smoking or by chewing the leaves? Please elaborate. Riaz, you want to take this one?
Actually, the marijuana is not really used in its crude form like marijuana. Just the way we have morphine, which is made into tablets and all that. So in US, it is now FDA approved, and they have tablets of marijuana at a certain dose, which they know that it is safe to the body. In Kenya, it's not yet approved, so we don't use it. There are some European countries as well where it has been approved, but generally in most of the world it is not yet really approved. But they are made as tablets with at a certain dosage, just like the morphines are. Because if you overdose onto those things, it can again create more problems for you. And maybe just going back on the question of the complementary therapies or the hydrogen and whatever. Right now, especially with this social media and everything, you'll find so many things coming up and making rounds all over, and something can just spread like wildfire. Today, Dr. Sitna can decide that cucumbers are very good for cancer and puts a small write-up and puts it on a WhatsApp, and in a short time the whole world will be forwarding it that cucumber cures cancer. So what we need to see is that whatever is being forwarded and whatever is being read even on the internet and the other sites, what test has it gone through? In medical field, for any drug or any mode of treatment to be approved, the topmost thing is for it to go an RCT, randomized clinical trial. Has this modality of treatment been subjected to a randomized trial, and what was the outcome? Has it been published in the journals, renowned journals? Has it been presented in the conferences and been accepted? So those are some of the tests which we can even advise our patients to look at before they take whatever is being forwarded as the truth. Like in oncology, most of the time in many of our clinics we have cancer support groups, and they form WhatsApp groups, and each day there are so many things which are just moving like wildfire, that do this, do that, do this, do that, and many of our patients come and tell us that I mean everything is deleterious, so what am I supposed to do? From what I read is that I should not eat anything at all, and that's the exact scenario what people would come into. So you really need to be careful about what is accepted truth and what is really not.
I think we are taking the last question, but the good thing is that the presenter will be hanging around, so you can go personally and ask them any question you want, and they are very approachable.
Actually, Dr. Riaz has answered what I wanted about the regulation of these adverts. Particularly, you can see some of them in even major newspapers. You see a small piece of paper with a lot of things. Really, that dilutes the public. How can that be handled at the regulatory level? That's what I wanted to say. Thank you.
Yeah, of course. So the board also needs to come, the pharmaceutic boards, and they also need to come into play at this juncture. And I hope they will.
Sorry, there was a question that was forwarded a while back. Yeah, a question: patient with stage 4 with mets all over, and has no signs of life, requires resuscitation. Should you proceed, considering that this patient might be needed to be in ICU after that, if I remember the question correctly?
Essentially a stage 4 advanced disease, whether to resuscitate or not. So, I mean, it goes back to what we do in Kenya versus what is done outside. I mean, we don't have a law of, we don't have any legal backing of things like do not resuscitate, whereas this would be a very simple decision in the West. They would not take you to the ICU, they would just discuss with your family. They wouldn't ask your consent whether to do CPR or not. But here we would have to have a discussion with you, with the family, and just tell them there is futility of care. Usually for our patients now, we encourage having advance directives, which is a discussion that, look, your cancer is not curable. If this happens, if you deteriorate, there's no benefit of taking you to ICU. And since we started having a full-time palliative care consultant, we found that the rates of taking very advanced patients to ICU has dramatically reduced, because we have these discussions before even they get to the point of do you need ICU care? We've already discussed that you're not going to improve with the ICU. Having said that, many times we still go through that because families are not ready, and they say they want everything done for their relatives. So you sometimes end up doing things that you know are wrong for patients. It's not a straightforward question. There are legal and ethical considerations, and there are patient and family views that need to be taken into account.
Yeah, true. Because generally, you need to look at what is the quality of life that the people are going to have, what is the cure rate, and if the primary disease is not curable and you are not going to have any kind of quality of life, even if you resuscitate and even if you put on the vent, then it is in futility. But all this discussion needs to begin earlier, and that's what I was talking about. Supportive care needs to begin earlier. If you start amalgamating all these discussions with the patient from the time you are starting to see them, then such kind of scenarios may not arise. It's essential to remember that palliative care in whichever field, whether it's oncology, whether it's cardiology, whether it's neurology, or in any field, it does not begin when the definitive treatment is ending. It begins when you have made the diagnosis, and the palliative care goes up as the definitive treatment is coming down. I think many of you have seen that curve. So that is what is important. Generally, it's not a very clear-cut definition, but once the definitive care has stopped, then it is called hospice care. But yes, the whole scenario needs to begin much earlier, and there would be no benefit of patient to be taken into ICU at the last stage. But it needs to be taken into consideration with what kind of a scenario the patient has. Sometimes there are patients with advanced cancers. They are already in stage 4, but whatever is bringing them down at that juncture, it's actually a controllable or a curable scenario. For example, like now, if there is a pulmonary embolism and you know that you can actually take care of that pulmonary embolism and give them more life in terms of months or years, that's a different thing. If it's sepsis and you know you can control the sepsis, that's a different issue.
Thank you so much for all the presenters, Dr. Abdi, Dr. Riaz, Dr. Yakub, Dr. Ali, Dr. Sitna, and Dr. Albert Kashau. I think now we'll move to the next series of presentation, but I think all the presenters are here, and if you have any question, you can approach them and ask them personal question. And I think if you haven't taken tea, you can just go and pick your tea and come back here. And also you can visit the exhibitors booth. Shukran, jazakallah khair.
hapa kwetu hapa ndio kaşıkçı gibi olmak lazım. Şimdi söyle tercümeyse radyo basar söylemesin. Böyle mi abi? Arabanın yürüyeni diyor. Otomobil. Ne deriz ona? Walking car. Walking car. Ahmet benimkini koymuyor daha. Benim şey yok. Süleyman konuşacak. Bizim Süleyman Bakari konuşacak. İçinde var. Niye konuşuyorsun? Öyle bir Assalamu alaikum wa rahmatullahi wa barakatuh. We are ready to continue with the next session. And it gives me great pleasure, Medical School of the University of Nairobi, College of Health Sciences. And she's been involved, got a keen interest in emergency obstetric care. So without taking much of the time, I hereby call upon Professor Zahida Qureshi to make her presentation on maternal sepsis. Welcome.
Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the organizers of this conference that they requested that I make a presentation on a subject of my choice, and I usually talk about postpartum hemorrhage. I decided to change a little bit. So I'm going to talk about maternal sepsis and also talk a little bit about the maternal sepsis study that we conducted. We are all aware of the Millennium Development Goals which finished, and now we talk about the Sustainable Development Goals, and we all know that goal 3 is good health and well-being, but we should also remember that we have number 6, which talks about clean water and sanitation, and using that to prevent infection, and then 12, which is looking at judicious use of antimicrobials to prevent infection. Okay. So in 2017, the WHO World Health Assembly came up with a resolution on sepsis and looked at improving infection prevention and control strategies by accessing clean water, sanitation and hygiene, that's WASH, continuing efforts to combat antimicrobial resistance, increasing public awareness of sepsis especially amongst high-risk groups such as pregnant women, ensuring prompt and recognition and presentation for treatment, training health workers to be able to recognize the importance of sepsis in critical medical emergencies, promoting research to develop innovative means to prevent, diagnose and treat sepsis, encouraging a safe and clean childbirth and surgical site infection prevention. So in the global era of sepsis, there are a lot of organizations that work on sepsis, and many bodies such as Surviving Sepsis Campaign, the Society of Critical Care Medicine, who in 2016 came up with a new sepsis definition, which they call sepsis 3, and that's organ dysfunction and infection, and they have SOFA, which is sequential organ failure score, and a quick SOFA, which is a modified form. So when researchers and the global stakeholders looked at what happens of its equivalence in the maternal health care, it was realized there is really no definition of maternal sepsis, so they convened a team of international experts and debated and deliberated and came up in 2017 with a definition, which is maternal sepsis is a life-threatening condition defined by organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion or the postpartum period, and this is published. So from there, WHO released a statement on maternal sepsis, said that it is recognizing the need to foster new thinking and to catalyze greater action to address this important cause of maternal mortality. We talk about maternal mortality resulting from postpartum hemorrhage and hypertensive disease and abortion, but recognizing that even in non-abortion patients, there is a big contribution of sepsis to maternal morbidity and mortality. So I'll talk a little bit about the study we did, recognizing this new definition. WHO planned to conduct a survey to assess frequency and outcomes of maternal sepsis in developing and developed countries, to assess the frequency of use of a core set of practices recommended for prevention, identification, and management of sepsis. And this was a 1-week inception cohort, all eligible women and their babies who were admitted to hospitals that were going to participate between a 1-week period, which was 28th of November 2017 to 4th of December. And there was a full protocol for the low and middle income countries and a modified protocol for the high income countries. So these are the 46 low middle income countries and 6 high income countries that participated in this global survey, who collected data in that 1-week period. So all countries were requested to pick one geographical area which had a population of at least 2 million. And within that population or geographical area, they would pick as many facilities that were conducting deliveries. In Kenya, we picked Nairobi as our geographical area because it has a population of more than 2 million. And we picked 11 hospitals out of the 198 that conduct deliveries in Nairobi. So basically, we were going to look at all women who were admitted in the facility and had sepsis according to the definition, either antenatally, post-delivery, post-abortion. And knowing that women will remain for some time, so we said all the women who we picked during that 1 week, we will follow them up until they get discharged, and the maximum we would follow would be for 6 weeks, which would end at 15th January 2018. So we had a lot of posters that were put up in all the sites, and one of these is for health, the general public, talking about the number of women who can die. Like globally every year, infections are the primary cause of about 35,000 maternal deaths, and sepsis can contribute up to 100,000 maternal deaths. So this is a very large figure. We've never heard of these figures before we actually internalize them now. Other posters for healthcare workers talking about how to recognize sepsis, how to prevent, and how to treat sepsis. So globally, this is the data we are sharing. This is not been published yet, so it's not going to be released out to all of you, but we hope to have the publications in the next few months. So we'll talk about the low middle income countries. There were 50 geographical areas in 46 countries. Some of them decided to use 2. And each country was supposed to give a figure of the total number of births the previous year for them to estimate. And in the week of study, they gave us exact figures of how many births occurred in those facilities. So Afro contributed to about 9,000 out of the 32,000 births that happened. The facilities, mostly public, urban, birthing facilities, many of them, exclusively maternity facilities like our Pumwani were about 82. 73% of them had adult intensive care units, and 63 had intensive neonatal units, and 94% of them could perform a cesarean section. So let's look at what we have. We're going to spend a minute or two on this slide. So out of the total population of women who were identified with sepsis were 2,928. We had to remove the data for chart because it had some problems. We had women who were hospitalized with suspected or confirmed infection were 2,908, and in-hospital maternal deaths during that period were 20, but they were not related to infection. Then we had those that had mild infection, which was 65% of the total data set, and 35 were those who had infections with complications. Of these, we had non-severe maternal outcomes, 23%, and severe maternal outcomes were 12%. This is this population here. And of those who had severe maternal outcomes, severe maternal outcomes related to infection, they had a infection-related near miss, which means they were very, very sick, but we managed to save them. They almost nearly died. Were 325, 24 out of the 350, and we had 26 infection-related maternal deaths. Out of this, 17 deaths were infection as the underlying cause, and In 9, infection was as a contributing cause. You can have a woman who comes in with postpartum hemorrhage, she has all the interventions, she has a hysterectomy, and at some stage she gets an infection. So it was not the initial thing. So this is just a repetition of the same thing. I don't know why I'm not moving. Okay. So overall rate of infection, we see that we have suspected maternal infection is 69 out of 1,000 live births. That was suspected, and confirmed was 56 out of 1,000 live births. Look at cesarean sections. We had 9% suspected maternal cesarean section infection, and 7.5% was confirmed, 7.4%, sorry. Again, looking at near miss, we have 9 out of 1,000 live births had a near miss associated with infection, and the maternal mortality ratio was 50 for 100,000 live births. So this is quite high. Look at some of the pregnancy outcomes. If we look at the mode of delivery and then looked at mild or complicated without severe maternal outcomes or complicated with severe maternal outcomes, let's look at the cesarean section. Here we have 61% for complicated without severe maternal outcome and 61. So what is happening to our cesarean section? Is it that we have more severe infections after cesarean section, or was it that the woman had a lot of infection which necessitated that cesarean? So also let's look at the use of evidence-based practices. We have recommendations from WHO on prophylactic antibiotics. So if we look at prophylaxis for cesarean section, ideally we are supposed to give prophylactic antibiotics for every cesarean. Prophylactic, let's understand there's a difference between treatment and prophylaxis. Only 86% of them got prophylactic antibiotics. Skin prep, we should have every woman getting a skin prep prior to a cesarean, only 87%. Prophylaxis for perineal tears, which is grade 3 and 4, 1 and 2 we do not expect antibiotics, only 55% got. And prophylaxis for manual removal of placenta, only 57% of them got prophylactic antibiotics. This is a chart from WHO. This is a 2016 chart looking at hand hygiene and the surgical patient journey. The patient comes in from the community, comes into a facility, gets prepared for surgery after a diagnosis is made, has maybe an IV catheter put in, urinary catheter, IV cannulization happening. She's prepared for theater. How do we do our hand scrub? How do we do the surgical prep on the abdomen or wherever the surgery is? In this case, abdomen probably. Then she comes out of theater. She has the catheter removed at some stage. The IV cannula is removed. Then the post-op wound dressing is removed, and then hopefully she'll be discharged. So what are the things that can go wrong? Many. If you look here, it says 1 in 2 surgical staff do not clean their hands at the right moment. Up to 31% of patients will get a surgical site infection, and the length of stay will increase by 3 to 20 days in those patients. So, sorry, it's not showing very well from there, but this is a cesarean section infection. It gets this bad. So in this pathway, where did we go wrong to have this result? This was a 16-year-old girl who had had a cesarean in a peripheral unit and was referred to us. So in the cohort that I was presenting, the study we did, we had these 11 hospitals. We had estimated that infection rate should be about 7% and calculated that we would get about 100 cases during the 1 week, but we only got 58, which is good. Infection was less than we expected. What were the things that we picked up in our cohort? We had more of chorioamnionitis compared to low middle income and high middle income countries. We had other infections a bit higher, and we had abortion-related uterine infection higher than the other countries, and secondary infection higher. I was sitting at the airport this morning and reading the BBC News, and I saw this. The Tunisian health minister has resigned following deaths of 11 newborn babies at a hospital in Tunis because of 11 deaths, newborn deaths. What would we be doing if we were to resign over maternal deaths? So in summary, I'm ending. Again, another of our posters to remember that maternal sepsis, women who are pregnant, who have had a miscarriage or have given birth are at risk of developing maternal sepsis. We need to know the signs and symptoms. We need to act fast. We need to stop sepsis so that we prevent morbidity and mortality. The theme of this conference is universal health care, so we should be providing care wherever we see women, right from the community to the lower level health facilities to the higher, so that we prevent maternal sepsis. Thank you very much.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Twaha, pediatrician based at Malindi Sub-County Hospital. Assalamu alaikum wa rahmatullahi wa barakatuh. I take this opportunity to welcome our Sheikh Jamaluddin, who is an imam and a khatib at Umar Al-Faruq Mosque, Nyali. Is also an administrator and lecturer at Raf International University. He'll present us a talk, what is expectation from our society about Muslim health work professional. What do they expect from us? What the role of a Muslim health professional to see what picture and a model to our society. So Sheikh Jamaluddin, welcome and speak to the audience.
الحمد لله رب العالمين وصلى الله على نبينا محمد وعلى آله وصحبه وسلم أما بعد. We ask Allah subhanahu wa ta'ala to grant us tawfiq and ikhlas, and we ask Allah subhanahu wa ta'ala to make this lecture to be beneficial, that will benefit in this world and in the hereafter. The topic that was allocated for me was the society's expectation from a Muslim healthcare professional. Before that, a question arises: why should you care about the society as a doctor? Do them having an opinion about you, does it matter? Yes, it does matter. What the society thinks about you does matter. The reason being, a hadith, the Prophet ﷺ, while he was in Medina, it happened that while he was sitting with the Sahabas, 2 janazas passed by. And the first janazas, they talked highly of him, and they said he was a good person and he did this and he did that. Then the Prophet ﷺ says, wajabat. And then another second janaza passed by, and the Sahabas complained that this guy was like this and that, and the Prophet ﷺ says, wajabat. If he was bad, he was bad. And the Prophet ﷺ was asked by the companions, what did you mean by wajabat? Then the Prophet ﷺ explained himself, and he said, the first person came and you talked highly of him. It means that he's a good person, and for that reason, he's going to enter his expectation from a Muslim healthcare professional. You should know that you being a doctor or a nurse or working at a laboratory, the opinions of people matters a lot for your akhirah. First of all, the society looks highly when you're a doctor. You have so much respect. I had that experience when I was checking in at the hospital. And they asked, "Weni daktari, Dr. Nani?" I just kept quiet. And they didn't check much, they just let me go. If I said a sheikh, they would have looked for a bomb everywhere. So anyway, that's just a joke. But any human being would respect a doctor. The moment you say you're a doctor, any human being, regardless of the language, of the religion, of the tribe, Allah subhanahu wa ta'ala has made you to be respected. The first thing that is expected from a doctor or any person working in the medical field is to preserve this respect and honor that Allah subhanahu wa ta'ala has granted you on a silver plate. Preserve it. And people are proud of you. In your family, definitely people say, "Fulani daktari, he's a doctor." They look highly upon you. So if that's the case, the first duty is you preserving the scholars in the Muslim society, scholars and doctors. But with us scholars, we've become irrelevant. Since we have Sheikh Google, they don't come back to us anymore. But as for you guys, the respect is still there. You're not irrelevant in the society. Unless some applications are made whereby you just put what are the signs, are you having high fever, this and that, and then they'll tell you have this problem and people will start looking for their own medication. If that time comes, then I'll feel sorry for you. But I hope it's not coming anytime soon, inshallah. Second thing, when it comes, whatever the society expects from a Muslim doctor is to be considerate. If someone is not able to pay the money that they asked for, you should try and find ways. If there's a way you could help with NHIF, you can tell someone, get NHIF. No sheikh will tell you NHIF is haram. And if any sheikh will tell you NHIF is haram, then he doesn't know the Islamic knowledge. NHIF is halal. But other insurances other than NHIF is not halal. There's something that you should understand. When it comes to NHIF, it's the duty of the government to take care of its citizens. When they're paying 500 shillings and they're getting services in return and they would pay more, that money is not coming from someone's pocket. That money is coming from the treasury, it's coming from Baitul Mal. And it's the duty of the government to take care of its citizens. But when we have other companies coming in, then hapo kuna difference of opinion. Up to now, I'm trying to find loopholes to see if there's a way we can give fatwa, because medical bills are making family to become poor. And up to now, sincerely speaking, I'm still doing research, and the day I get a fatwa or I reach to a point to know that NHI and other medical insurances are halal, I'll be the first to get. But NHIF, you should encourage your patients. Other than that, if there is a way you could reduce the rates. If you know someone is not well and cannot come to you because he's supposed to come and see you and he cannot pay the 3,000 shillings that when you pay when you normally visit a doctor, make it free for once. Not for everyone, but you know the situation of that person. Be considerate. Because these small things that you do matters a lot. And you don't have to tell anyone. You see, as a Muslim, you should have deeds that are secret. I'll give you one example. During the Khilafah of Amir al-Mu'mineen Umar ibn Khattab radiyallahu anhu, while he was the Khalifa, he would roam around during the night and he would look for people to help. And one night, Talha ibn Ubaidillah saw Amir al-Mu'mineen Umar ibn Khattab leaving, going out during leaving Medina, outskirts of Medina. And he decided to follow him. So where is this guy going? So he went behind him, and there was a house. And Amir al-Mu'mineen entered that house, and he stayed for a while. And he left. And Talha was was asking himself, what's going on? So he went there and he found a lady inside the house. And that old lady was blind. And he asked her, who is this guy coming to you? She said, I don't know him, but he comes every night and he cleans my clothes and he makes my food and he leaves. And I don't know who it is up to today. And Talha felt so much pain in his heart and was like, why am I spying on my brother and he's just doing something good? The scholars have said that as a Muslim you should have deeds that are secret. If you have a patient and is not able to pay, it's an opportunity for you to invest in your akhirah. Please consider that. The third thing is what the society expects from you is to do your job very well. When you're doing a surgery, when you're meeting a patient, there was an example, like I was writing this down, I don't know if this is the right pronunciation. Which type of bilirubin will you find in the urine? And everyone was quiet. I was like, how come people don't know the answer? But either way, I don't know if it's the liver or hepatitis A or whatever, but I got lost in between. But whatever I'm saying is, do your work very well and study. And this is the expectation of the society, is because they entrusted you with their lives. So when someone trusts you with their lives and your opinion matters to them, then make sure that you've done your homework very well. Make sure that you have the right knowledge. If you don't have the expertise and you feel like you've not reached that level, it's not a problem. You can refer to another better doctor or a very well experienced doctor. Another thing is what you expect from you doctors is that you should have some empathy, or what would you say, at least have mercy within yourselves. You know, when a patient is going through pain and you tell them, huyu ajifanya kitu kidogo, that's being very insensitive, because you don't know what that person feels. I know of cases where patients would delivery room, and patients, I've heard of cases where patients would deliver and the doctors or the nurses will slap that lady. No, it's a lot of pain. I have the experience. I've not experience. Don't get me wrong. I've been in the delivery room and I've been with my wife, alhamdulillah. And the doctors, they have not slapped my wife. They've been very loving. Dr. Tanwira, Dr. Ruki, alhamdulillah. They've never disappointed. But what I'm trying to say is, do not be insensitive, especially when someone is going through a lot of pain. You don't have, if you've never given birth, you don't have to experience the pain of giving birth so that you understand what that person is going through. So also what we expect from me is to be considerate. Another thing is, my fifth point is, when you're writing medical prescriptions, it's very important that you know Allah subhanahu wa ta'ala has given you a duty. And when you're prescribing a medication, do not prescribe a medication just because there's something you're getting out of that company or incentive or commission. That's very unethical. If you know that there's a medicine that would work better for this patient, but you'd go back and write that medicine that will not be very effective in such situation, and you know there's a better medicine that would work, but the only reason you're prescribing this is because you're getting something out of it, that's very bad. So I haven't seen a case like this, but I've came across an article, and I've had, as Muslim, as scholars, we've been asked such questions. Can we accept gifts from pharmaceutical companies? Can we accept this? Then we'd want to know, are there any strings attached? Because when you have these pharmaceutical companies giving medication or giving gifts, well, that's not the right way for them to compete. The right way for them to compete is by producing the best medicine. But when they give something to the doctors and the medicine will go, that will not make them to work harder and improve in producing better medicine. But I've not had any case, but I've been asked these questions. Another thing that we expect from the doctors is, when you have a patient and that patient is admitted make an effort to visit that patient as fast as possible. Especially if there's a surgery that has been done. They have a lot of questions. And I know some patients are very nagging. And they really bother you at times, and they call you and this and that. But you see, try as much as you can to go and visit those patients. Why am I saying this? Because first of all, you have a responsibility. First of all, you have a responsibility. Second thing is because these are deeds that will benefit you on the day of judgment. And if you don't do that, you'll be blamed on the day of judgment. How is that? Do you know that when you visit a sick person, and let me rephrase that. If I'm to go for Umrah, or I'm going for Hajj, and then you hear that I go for Hajj, or I'm going for Umrah, what would you ask of me? Quick question. Make dua, right? Okay, that's the answer that I was looking for. Imagine that when you visit a sick person, narrated a hadith that is sahih, 70,000 angels make dua for you. Allahu Akbar. 70,000 angels make dua for you when you visit a sick person. If I just go and visit a sick person, that is the person who's visiting. What about the one who's taking care of that sick person? He's giving medication to that person. You get more ajr, definitely. So don't lose on this type of ajr. At the same time, the Prophet ﷺ stated in a hadith that Allah subhanahu wa ta'ala will make his slave stand in front of him on the day of judgment. And Rasulullah ﷺ says, Allah would ask him, "Oh my slave, maridtu falam tazurni." "Oh my slave, I was sick and you never visited me." And then the slave would ask, "Oh Allah, how can you be sick? And how could I even have visited you?" Allah would tell him, "You knew there was my slave that was sick and you are capable to go and visit him, yet you did not do." If that's what I'm asked, just being a neighbor, I've had mwenzangu mgonjwa, mwenzangu amelazwa hospitali, and I didn't go. What about you being the doctor who did the surgery, who gave the letter for that person to be admitted? Definitely you have more questions to answer. I don't know if you're getting the issue. So it's a responsibility, and also it's an opportunity for you to get ajr, where 70,000 angels, then the Prophet ﷺ said, they will not just make dua for you once, they'll be repeating this two dua, Allahumma ghfir lahu, Allahumma arhamhu. Oh Allah, forgive this slave. Oh Allah, have mercy upon him. Not once or twice, from morning till evening, sundown. They will not do anything, they'll just be asking dua for you. So inshallah, we'll take advantage of this opportunity, inshallah. Last but not least, because time's up, and I'd wish if the cameras had been off so that I can mention this, but anyway, last but not least is you sticking to your religion. It's very important that just because you're a doctor and you think that you have an excuse kuingia katika surgery and then swala 4 au 3 zinakupita hivi hivi, go back to the scholars, ask, how am I supposed to pray? The surgery took 7 hours, the surgery took 9 hours, because you have a duty upon Allah subhanahu wa ta'ala. So observe your religion and know that the first thing that Allah would ask us on the day of judgment is our prayers. So we ask of you to stick to your religion. There are things in this world you can compromise, but salah is not one of them, because that's the first question you'll be asked on the day of judgment. Other than that, you give time to your family, and expectations in your family is very high. When your uncle is sick, when your auntie is sick, when your parent is sick, people's like, "Na mtoto wangu daktari." When your uncle is admitted, it's like, "Let my son come, let me see what he says," because they trust you. So don't feel tired, no, wasumbua kila saa. No, just do your part, because when you do good for your relative, you know what? Ajr is twice. If I give sadaqah to my cousin and I give sadaqah someone I just met at the masjid, when I give sadaqah to my relative, I get twice that, I get double the ajr. So what I advise you is take care of your family and be professional. At the same time, observe the rights of each party. Observe the right of Allah subhanahu wa ta'ala. Observe the rights of the slave of Allah. Observe the rights of your family, your husband, your wife, and work on improving yourself towards the path of Allah subhanahu wa ta'ala. 2 minutes left. Why am I saying this is because there is a trend that is coming right now in the Muslim community whereby parents don't want their female daughters to pursue medicine. The reason being, the sisters in the who are practicing medicine or are doctors, they don't get married very easily. Maybe they're too busy. Maybe men are afraid they're not up to the challenge. I personally wouldn't mind getting married. Anyway, I'll let that go. But as a man, you should not feel challenged. You know, if you have a wife who's a doctor, she's serving the community. She's serving the community. But what I'm trying to say is, as brothers, you should stand up for your sisters and marry them, even if it's a second wife, rather than her being 30, 40, not getting married. That's my advice to the brothers. As for the sisters, be willing to compromise. Because as age goes by, you know you have to become a mother. Men, sometimes they feel challenged, but at the same time know that in this world, Allah subhanahu wa ta'ala has created someone for you. You'll find him, but be willing to compromise some of the things that you're supposed to do. I wish the camera was off, but I'll stop it there. Inshallah. We ask Allah subhanahu wa ta'ala to bless you. You're serving the community, and inshallah, we'll all meet in Jannah, inshallah. Barakallah. Thank you for your time. I have to nataka niwahi swala ya dhuhuri. Maybe 2-3 questions kwa haraka kabla sijatoka. Allah Akbar. You don't clap for me, eh? No.
Hello? Questions? All right.
I think it's, sorry, it's not the right paper, but I remember the question. Someone said Muslim doctors or healthcare workers spend so many sleepless nights to get their degrees, but unfortunately they can't spare even time online or whichever case to get a certificate in Arabic, for those who do not understand Arabic, that is, to at least understand one volume of the Quran. Alhamdulillah, we have some medical professionals in RAF. Can these Muslim doctors work hard to know Arabic and the Quran at least the same way they had sleepless nights to get their degrees? Shukran.
So what was the first question? Your question?
It's more of a comment.
Okay.
What do you advise?
Okay, Bismillah, Alhamdulillah, Salatu Rasul. First of all, it's not a must for you to learn the Arabic language, but it's a must for you to be able to recite the Quran. Let's first get our facts right. If you know how to recite the Quran, then you're supposed to make more effort, at least to learn what Allah is trying to tell you. If one of you, we have a brother from Turkey, if Erdogan will write a letter to us, or whoever who's here, won't you make an effort to find someone to translate that for you? Well, this is a letter from Allah. Wouldn't you make an effort for you to try and learn what Allah is trying to tell you? So basically is make time to learn your religion, and at the same time you should know that knowledge is of two types. There is knowledge that is compulsory for every Muslim who should know. That knowledge is fard ain, and by hook or crook you should learn this, and you should make sure your children know this. How to pray, if you have wealth, how to give zakah. People are giving zakah, but they're giving it to the wrong people. Do you know that if you give zakah to the wrong people, you're supposed to give that zakah again? So I had a case last year, someone gave 500,000, it went to the wrong person. I told him, no, you need to find it, you need to get money and give it to the right person, because wajibu hiyo bado iko. So if you have wealth, how are you supposed to give zakah? How are you supposed to fast? If you're in a surgery, in your bed, always get keeping outside. So my advice to you is, first of all, learn the basic things that you need to know. Salah, zakah, Sawm. If you haven't gone for Hajj, make sure you go for Hajj and learn about doing Hajj before you go. If you're done with the basics, Alhamdulillah, the other things are secondary. But the problem right now is the Muslim Ummah, we are struggling with the basics right now. Barakallah.
Shukran, Jazakallah khair. It's another.
There's another question. This is touching on the doctors. Is it halal or is it haram to go on strike to fight for your rights, or other? What other options do you have?
I'll pass that question. Go ask Dr. Islam. He's more learned than me.
There was also another question already been posted on salah. You mentioned about salah during long surgeries. I know it might be a bit of a long, but what are the options? Do you pray prior to it? Do you pray after?
You cannot pray salah before the time comes. If, for example, I pray dhuhr before the time of dhuhr. Allah subhanahu wa ta'ala says, Inna salata kanat al mu'minina kitaban mawquta. It's a prescribed time. There are certain situations. There are situations that you've already planned. You know that this surgery will just take 1 hour. But guess what? It ends up becoming 6 hours. So this situation is different from you knowing that you know the surgery, when you enter the surgery will take 6-7 hours. So in that situation, it will differ from one situation to another. And at the end of the day, I asked this from last year and the previous year. Last year was in White Sands, right? Yeah. And the year before that, I asked and I proposed that they should put up a website for the Muslim doctors where we can post these Q&As, FAQs, frequently asked questions, so that any Muslim doctors, I don't know how long that would take, maybe KAMMP would come up with that. But right now, I'd rather not answer that question because it differs from an individual person to another individual person. We must know the situation so that we give the fatwa.
Assalamu alaikum.
Wa alaikum salam.
Yesterday, we were told about it's okay for someone to donate an organ. So I did my research. There was an article, Tabarruk bil A'zam. But my concern is, in Islam, it is not okay for a body to be mutilated, a dead body. So is it okay to harvest an organ from a dead body? That's my question.
That's my question. Up to date, there's a difference amongst the Muslim scholars. You see, the scholars have two things that would always bring challenge to them. And they're always new cases. That is finance and medical. And these are things, but Salah is always the same, Hajj is always the same. But you know, when it comes to the finance, like right now we have questions on Islamic bank and taking loans and, you know, new terms that we've never heard of. On the other side, you have the medical field. These are two fields that always come up with new situations. So these are situations that were not there maybe even 50 years ago. The scholars right now have a difference of opinion. And I know one of the scholars who's adamant and is saying that he's a scholar, he's one of the scholars in Saudi, it's called Dr. Abdullah al-Mutlaq. He said, giving out, I don't need this. This is an amana from Allah subhanahu wa ta'ala. But I gave it out for the sake of to save another fellow human being. I don't need it when I go to the grave. In fact, he said, when I die, make sure you harvest my organs and you donate. So right now, there's still a difference of opinion. And up to now, I'm a student. I can't tell you what's right or what's wrong. But I'll advise you to visit this website, www.islamqa, Islam question answer, islamqa.com. Islamqa.com. It's a very beneficial website, and inshallah you'll get a lot of questions, answers and questions from it. It's an authentic website. Last question.
Assalamu alaikum. Shukran, Sheikh. First of all, the issue about beating the patient. I happened to beat, I was a student that a midwife slapped a mother and I slapped the midwife. And when I asked her, she told me, you know what, she will either kill this baby or go with somebody who is having brain damage. So it's, you know, sometimes, you know, purposely you are trying to save that. But I would like you to differentiate the difference between NHIF and me using another medical insurance. I pay the money, or the government pays on my behalf. And that's the money which I use for myself and family. What is the difference between the two? Okay. Thank you.
I'll answer the first other question. When it comes to beating, if there is a reason why you're beating and labda it would help and would save the baby, because I've seen a case of a relative who was in the delivery room and the baby was about to come out and the nurses would say, no, wait. I don't know why is it a must for them to wait for the doctor. And the lady can just deliver. And what happened is, I don't know, is it the amniotic fluid or something? The baby took a lot of water. I don't know where the hell that water came from. And then mtoto ikabida to ICU, and then a lot of complications came just because mtoto anazuia asitoke na mtoto ataka kutoka. So I don't know what's the reason why. I just, up to now, I want to understand. Maybe someone could explain why the nurses can do the job and the job is ready and you still have to wait for the doctor, and if you delay it will cause complications. It hasn't happened to me, but I know a case that happened. But another case is, if you slap that lady to save a life, why not? Why not? You can do that. I'll tell you a story. My first wife, my first child, was delivered by a lady called Gita Shah. But you see, since it was my first child, and you know, she ended up slapping my wife. But she saved my daughter. That's why I have my daughter Amina. But she doesn't want to see that doctor, so we moved to Dr. Rukia and Tanwira. But either way, I'm very thankful she slapped her, because guess what? I will not have my lovely Amina today. So it depends with the situation. So second thing is NHIF and medical. You need to know that there's something that is called uncertainty, gharar. Whenever you go to an insurance company, and I give them money, like 10,000 every year or 100,000, it's not known when I'm going to benefit from this. There's this uncertainty. On the other side, after 2 months, something happens to me and I end up being hospitalized and they pay 4 million, and that's not good for them. You get it? But when it comes to the NHIF, it's different. If I'm giving money, I'm giving it to the treasury and it's going to the Baitul Mal. And if that money is coming out, it's coming not from the president's pocket, it's coming from the same Baitul Mal. That is the difference between NHIF, because it's a national health insurance fund, compared to this private like APA or Jubilee or anything. So my advice to you is, when you have a patient who wants NHIF, don't think twice, because it's government-based and it's 100% halal. But when it comes to other insurances, believe me, sometimes I even ask myself, could it be halal? Is it about time that we accept this? Because we can't. The medical bills are just too much. I've seen people selling properties. I've been a witness where a body was held for 1 month or 2 months, and we had to take a title deed from someone so that we get done with that. Someone would give us his land, and I think it's about time, like, if we really find scholars who would consider this, the situation, je, hii inaingia katika dharura ama haingii. But I'm still a student of knowledge and I cannot give fatwa on that. But his NHIF is halal 100%. Don't think twice. Ahsantum wa jazakumullah khair.
Jazakallah khair. How I wish that you will be our imam today as we go and pray downstairs. But I know you have other callings outside there. Jazakallah khair. Barakallah fiqh. Brothers and sisters, we are going to continue, and here I take this opportunity of welcoming Dr. Suleiman Bakari, who is a pediatric cardiologist here in Mombasa in private practice. Welcome. He's going to present recognition of critical congenital heart disease. And just as a tailor, in the afternoon, we were meant to have counseling of a diabetic patient, but instead it is going to be replaced by the role of a critical care nurse. Do we really need that critical care nurse. So just warm yourself for that talk that is going to be by Sister Jamila Jizan.
Assalamu alaikum wa rahmatullahi wa barakatuh. I want to take this opportunity to thank the organizers of this conference for inviting me to give this talk. Mine will be very brief. You can hear me? Okay. I'm going to talk on recognition of critical congenital heart diseases. Congenital heart disease is the most common among the congenital defects. Heart disease is the most common one, and critical congenital heart diseases is those defects which will need surgery or transcatheter intervention before the first year of life. About 10 in 1,000 babies will be born with congenital heart diseases, and 25% of these ones will have critical congenital heart diseases. These critical congenital heart diseases are the ones which lead to morbidity and mortality in the newborn period, that is before 1 year of age. As you can see from this diagram, some of the congenital diseases like cystic fibrosis, hypothyroidism, phenylketonuria, you can see the incidence of congenital heart diseases is about 2 in 1,000. Critical congenital heart disease about 2 in 1,000, okay, which makes them more common than the other congenital defects. There are several defects which are classified as congenital heart diseases, but there are 7 which are most common, like hypoplastic left heart syndrome, pulmonary atresia with the intact septum, tetralogy, transposition, tricuspid atresia, truncus, and anomalous venous return. So many infants can be identified by fetal echocardiogram, that is prenatally, but most of these in those areas whereby this service is not available, the prenatal ultrasound, they can be discovered after birth. Changes in the structure and function of the newborn heart can lead to critical congenital heart diseases going unrecognized during the newborn hospital stay, and they can lead to morbidity or mortality. If unrecognized, critical congenital heart disease will result in a sudden death or deterioration of health conditions. Infants who have critical congenital heart diseases, they might be normal physically immediate after born. There'll be no mama, no cyanosis, but they will have a relative hypoxemia, okay? And this hypoxemia may be undetected, especially in babies with dark skin, okay? So pulse oximetry can identify hypoxemia in these newborn babies, which cannot be seen clinically. And this can be used as a screening method for critical congenital heart diseases. So pulse oximetry can complement the clinical examination in detection of critical congenital heart disease by identifying or recognizing clinically undetectable hypoxemia. And early detection of critical congenital heart disease can significantly reduce this morbidity and mortality in the newborn period. There are several studies which were done on pulse oximetry in newborn babies, and this one lead to pulse oximetry being recommended by the U.S. Department of Health and Human Service Secretary Advisory Committee on Heritable Disorders in Newborn and Children as an important screening tool for detection of critical congenital heart disease in asymptomatic babies. Most of these babies with the critical congenital heart diseases will be asymptomatic in the newborn period. So this recommendation was also endorsed by the American Academy of Pediatrics as a standard care of newborn children. So basically, these newborn children are susceptible to sudden worsening in clinical status in the first days of life, the first days of the first weeks, and these changes correspond to changes in pulmonary vascular resistance. So neonates with critical congenital heart diseases, they have adductors, which is often essential for maintaining either the pulmonary or systemic blood flow, okay? And these defects are called ductus-dependent lesions. So in the first few weeks or the first few days of life, these babies are normal due to the ductus arteriosus, which maintain either the pulmonary flow or the systemic flow, okay? So the newborn hospitalization provide a critical window for caregivers to identify these babies with clinical congenital heart lesions in order to avoid hemodynamic embarrassment later on. And this timing of the constriction or closure of the ductus is always explains why children with congenital heart disease, critical congenital heart disease, may be particularly vulnerable to cardiovascular collapse soon after discharge from the newborn period. So it is very important to recognize these babies, and screening methods can be used to recognize or to identify critical congenital heart disease children. One of these, as we said, is prenatal ultrasound or prenatal echocardiogram. The other one, which is simple method, is the pulse oximetry. Okay, this one is simple, cost-effective, accurate, and easy to incorporate into the workflow of the newborn nursery. It doesn't need much knowledge, okay, and can be used in most nurseries. It can also be incorporated in there as a working tool, and information can be passed to the nurseries to use in the developing policies and procedures to implement this screening procedure. So we have said these babies in the first few days or the first few weeks, okay, they appear well. Why do they appear well? Because of the ductus, which is open. We call them ductus-dependent heart lesions. And these ductus-dependent heart defects are those in which the right heart supports the left heart, or the left heart supports the right heart. So ductus arteriosus, in short, is a connection between the pulmonary artery and the aorta before birth. If there are significant problems with the left heart, the ductus can provide a shunt, okay, which can make the baby live for a few days or few weeks before the baby can heart defect, in which a baby may appear entirely well at 2 days of age and become critically ill or die in the next few days. The other one is single ventricle. These are also, there are many types of heart problems where one of the ventricles is too small or does not function adequately. These babies will have no symptoms immediately after birth and behave more like a child with a left to right shunt defect. So pulse oximetry is very helpful in these settings, as blood oxygen levels in these babies is almost never normal. But clinically, you see the baby being near normal. There is no cyanosis, but there is hypoxemia, which can be detected by pulse oximetry. So pulse oximetry, the role of pulse oximetry in detecting or recognizing these babies, it has a sensitivity of about 76% and specificity about 99.9%. For every 3 detected, one will be missed, okay? But pulse oximetry is not meant to replace the clinical examination or echocardiography. This is